Hello, welcome to the symposium entitled Delivering What Matters, Hypertension Management with Renal Denervation and Management of High Bleeding Risk Patients Undergoing Complex PCI, sponsored by Medtronic. The objectives of these sessions are to learn about the latest evidence and safety profile of renal denervation. 2 is to learn about the treatment or effect of renal denervation. 3 is to review existing evidence on high bleeding risk patients treated with PCI. And 4, to learn about the complex PCI strategy in high bleeding risk patients. My name is Hui Chim Tan, and with me in the studios are Dr. Paul Ong and Dr. Chi Teng Ching, all from Singapore. In this symposium, we have also international speakers in Dr. Shaiful Asmi bin Yahaya, Dr. Azari Rosman, and Dr. Tiong Kiam Ong, all from Malaysia. These sessions will not have served its purpose of being an educational event without you, the audience, participating in. So I'd like to welcome all of you who are logged in to type in your questions and comments onto the chat post. We will try to answer all your queries as much as we can. And today, Dr. Alan Fong from Malaysia will be your Chatmaster, actively engaging with you online. For selected questions of interest, Dr. Chi Teng Ching, who is also the moderator for these sessions, will also raise it for discussion with the studio and remote experts. So I'd now like to begin by inviting Dr. Azari Rosman to give us an introduction to renal denervation, an overview of historical data, and where we are today. Azari.
Thank you for your kind introduction. What I'd like to do now is to introduce to you what the GSR program, the Global Simplicity Program, is about. And this is about the real-world accumulation of data regarding patients who have undergone renal denervation since 2012. To date, it has accumulated 3,000 individuals. And indeed, since this year, May this year, it was announced that it will be extended into the GSR Define category. So this GSR Define will actually look at individuals, another 2,000 individuals who will undergo or have undergone renal denervation, and to look at how their blood pressure is controlled following the procedure. These individuals are your real-world patients and therefore are on medications. And indeed, some of them are difficult to manage patients with hypertension, such as renal failure, diabetes, and so on. So in other words, this accumulated data will give us more knowledge in terms of what renal denervation will show in terms of the sort of patients you will see, you and I will see every day. So with that, I'd like to invite Dr. T.K. Ong to give his discourse on the real world experience of renal denervation, a little bit more about renal denervation experience from his center. Thank you very much.
All right, let's have Dr. T.K. Ong to talk to us about hypertension management with renal denervation, looking at GSR, the Global Simplicity Registry.
In this presentation, I will talk about the role of renal denervation in the management of hypertension. These are my disclosures. The Global Simplicity Registry is an international multi-center registry of patients treated with the Medtronic renal denervation catheter. It represents the largest and longest follow-up of patients who had undergone renal denervation in the real world, with up to now 3,000 patients enrolled. Of these 3,000 patients, nearly 2,600 of them have 3-year follow-up data for analysis. These are the GSR 3-year results. As you can see, after a single renal denervation procedure, patients in the GSR experienced significant reductions in the blood pressure of about 13 millimeters of mercury at 6 months. And there was further improvement in the blood pressure of up to 16.7 millimeters of mercury at the end of 3 years. There was a corresponding fall in ambulatory blood pressure as well. This improvement in blood pressure was achieved without an increase in medication. In fact, if you look at the right side of this slide, you can see that the mean number of medication types actually decreased slightly from 4.55 to 4.33 over that period. At the same time, the proportion of patients with an office systolic blood pressure of less than 140 increased threefold from 13% to 39%. This suggests that the reduction in blood pressure was likely due to the renal denervation procedure and not because of a change or an increase in medication. The other question that is often asked is whether the improvement in blood pressure that we see after renal denervation actually translates into a reduction of clinical events such as stroke or heart failure. To answer the question, one must remember that numerous hypertension studies in the past, including meta-analysis such as these, have shown that the clinical benefit of blood pressure lowering was directly proportional to the absolute decrease in blood pressure and was independent of the type of medication used. Therefore, there is no reason to believe why the blood pressure reduction achieved through renal denervation should not produce the same cardiovascular risk reduction. Hence, based on that assumption, and knowing the average blood pressure reduction achieved in the GSR population over a period of 3 years, it was possible to use meta-regression methods to estimate the reduction in major adverse cardiovascular events or MACE over 3 years in the GSR population because of better blood pressure control. This benefit, which was a reduction in MACE of about 25%, was seen in the overall GSR population, as well as in specific high-risk subgroups, such as the diabetics, the elderly, and those with high cardiovascular risk. In summary, data from the Global Simplicity Registry demonstrated that in the real world, renal denervation produced statistically significant reductions of blood pressure of up to 16.7 millimeters of mercury at 3 years. And this improvement in blood pressure control potentially led to a meaningful reduction of MACE in those patients who were treated with renal denervation. Thank you.
Thank you very much, TK. That was a good overview. Certainly, the GSR study does give a lot of information. So I'd like to ask Paul, just in a study of this nature, what is it that will support your adoptions of RDN in treating your patients with hypertension? Is it the efficacy outcomes, or is it the efficacy in terms of reduction of BP? Or is it the safety of the procedure? Or must you see outcomes here? Because this is not a direct outcome study here. This is just an estimated risk of reduction of MACE. So tell me, what is your most important considerations?
Thank you, Hui Chim. Those are really, really good questions. Now, from the clinical data we have, the HTN spiral on and the off trial both now demonstrated efficacy of renal denervation in controlling blood pressure. There's a meaningful drop in blood pressure. The GSR registry demonstrated the effect is lasting up to going up to 4 years. And all the data so far have demonstrated being a very safe procedure. So I think it's a combination of the safety and the efficacy of the procedure which makes it attractive. Now, I would be thinking, what type of patient would I particularly find it useful to use renal denervation on? And I think that those are a group of patients which have resistant hypertension, especially the younger patients. I think those will be particularly likely to benefit from it. Because you see, if RDN is performed on this patient, there is obviously a cost to the procedure as in doing a procedure on this. But the benefit, you see a longer runway to see how it will benefit this group of patients. And TK early on mentioned, lowering the blood pressure, significantly reduce the subsequent risk of stroke and heart failure. So I think this particular group of patient we should pay more attention to.
Right now, RDN is still labeled as an experimental therapy in the ESC guidelines, latest hypertension guidelines. So Now, who do you think will, as you scan the, the literature right now, I think only Taiwan and perhaps SCAI have some kind of recommendations with regard to the use of RDN. So what do you think are the group of patients that are likely to benefit most?
I think still the patients who are resistant to multiple medications, despite 4 drugs, still have poor blood pressure control. Or those who actually continue to have various kind of side effects, and you are rotating drugs one after another, those group of patients will be really suitable to have RDN. And in Singapore, in this part of the world, the procedure is actually HSA approved.
Yeah, in fact, SCAI actually put priority on people with resistant hypertension, but at the same time, at the elevated cardiovascular risk as well. So if you have multiple comorbidities, or that you actually have got already evidence of target organ damage, hypertension mediated target organ damage, then perhaps this group of patients should be considered for RDN, at least for now. So, Chiteng, RDN is not a new technology. Way back in 1930s, 1950s, we were talking about surgical sympathectomies for treatment of patients with resistant hypertension. It's just that in the last decade or so, we have moved on to percutaneous. So when you look at all the trials that have been reported, you look at the magnitude of the BP reduction. If you look at the ambulatory BP monitor readings, we think that maybe a 5 milliliter mercury is good enough in saying that a particular drug is useful. So now you have a RDN that seems to be able to lower the BP to the same magnitude, roundabout. So do you think this will lead to a reduction in the patients who are already on antihypertensive therapy, as GSR suggests? Or do you think that it just merely prevents the addition of a new antihypertensive just so that the BP can be better controlled?
Yeah, that's a great question. So I think the first thing to say is that in the 1930s, when we did all these sympathectomies, they came at a considerable cost of morbidity. Big operations, people became, had a lot of side effects from it. So the percutaneous option, as we know now, is very safe. Yeah? And the magnitude of improvement with renal denervation, typically quoted as about 10 millimeters mercury in office blood pressure, maybe about 5 to 9 millimeters on ambulatory blood pressure. In various groups, patients on medication, without medication, etc. Some people look at this and say, oh, it's not a big deal. But as TK Ong already very elegantly said, this comes with a significant reduction in cardiovascular outcomes. So about 20% reduction in cardiovascular outcomes. So what do you tell your patient in the clinic? I think when I talk to my patients, I don't sell this as a therapy to try and reduce medications. This is an adjunct, because any kind of improvement on your blood pressure is going to translate into an improvement in your cardiovascular outcomes. And that is what people want. People don't want to look at a number that's changing if it doesn't translate into a reduction in heart attacks or heart failure or dying within 10 years. So I think that's the way we should look at it. We should think about it as an adjunct. If some patients can reduce medicines, as some of the patients in GSR did, that's great. But we shouldn't be telling our patients that this is primarily a way to get you to take less pills. It should be a way to try and reduce your overall risk of cardiovascular problems in the long term.
So Chiteng, so obviously patient preference is a big thing here. So you have to talk to them, a choice here between adding a new antihypertensive therapy to lower the BP or to consider RDN and so forth. And RDN is of course not without its own risk in terms of performance. So how do you communicate with the patients? I mean, how do you tell them exactly when should RDN come in?
Yeah, absolutely. So in a therapy for a condition where people actually feel nothing, right? Most people don't feel a problem with their high blood pressure. It is very difficult to impress upon them the importance of an additional treatment. So you want to do something that really is very, very low risk. And thankfully, we have very good information from GSR now. I think TK Ong mentioned this very briefly, but the safety data from GSR this 3, 4, 5 years is that the safety profile of patients who undergo RDN is very, very good. There's hardly any issues. Some people, when they look at the name renal denervation, they think maybe, there's going to be some problem with the kidney in the long term. There really isn't. There's no increased incidence of renal artery stenosis. There's no increased incidence of renal failure. In patients who have some moderate renal impairment, GFR less than 60, they still do as well as patients with so-called normal renal failure, normal renal function, and they don't get additional jeopardy. So I think really the safety profile is the main redeeming quality of renal denervation. There's really very little cost to this in terms of safety, and the efficacy, I think we're getting more and more information about how good it is. So I think this is very reassuring to our patients.
Yeah, indeed. I think most of the vascular complications are actually vascular, and probably less than 5% is most of the reported series here. So you mentioned about renal failure patients. The trouble is that a lot of chronic renal disease patients have hypertension, and many of these patients are actually excluded from the clinical trials. So would you offer this RDN to somebody with end-stage renal failure with resistant hypertension, or EF, GFR less than 30?
Yeah, good question again. So actually the trial systematically excluded patients with GFR less than 45. We have data from GSR looking at 60 as the cutoff between normal versus renal impairment. In that kind of data, it was fine. There was no signal of any issue. We have ongoing studies in GFR less than 45. I think the anecdotal evidence is that there really is no increased jeopardy in these patients. I think we also have to kind of bear in mind about what the mechanism of hypertension is in patients with end-stage renal failure on dialysis, really profound renal failure. It may not really be sympathetically driven, and so hence the degree of benefit that one may derive from renal denervation may also accordingly be tempered.
Paul, I want to ask you, is this BP reduction effect of RDN permanent? Do you think it's transient like a vaccine, or you think it's a permanent thing that will go on?
I think if we look at the data that TK had early on presented, the effects, the blood pressure reduction effects actually gone up to about 4 to 5 years. And he also demonstrated in one of the slides that the number of medication did continue to drop in that group. So it seems to be a very promising and lasting effect, Hui-Chin.
So that's something that very encouraging, and we certainly would like to consider it if it's gone into the guidelines proper, and that the cost is a little bit more manageable for our patients. So certainly it is a novel technology that with a lot of answers, there's questions that still beg answers, but I'm sure more and more data will surface in the near term that will guide us in choosing the right patients for this RDN technology. So I want to switch gear a little bit. I want to go on to talking about PCI management in patients with high bleeding risk. And I'd like to start off by basically giving a little bit of a rundown on what PCI in high bleeding risk is all about. So what is PCI in high bleeding risk? So there's a definition from the Academic Research Consortium consensus that high bleeding risk patients are defined as those with BAC3 or 5 bleeding risk of more than 4% at 1 year, or intracranial hemorrhage of more than 1% per year. So for those who are not so familiar with BAC3, is really about patients, BAC3 and 5 are really about fatal or serious or fatal bleeding risk in patients. And certainly we know that a number of conditions actually increase a patient's bleeding risk, but some are actually more important than others. And so if you look again at the ARC criteria, there are major criteria as well as minor criteria. Certainly if you look at the anticipated risk of long-term oral anticoagulations, people with severe end-stage renal kidney disease, these are these major criteria, but just the sheer age alone is considered a minor criteria. So let's take a look at the Onyx 1 global study design, which is obviously a pivotal trial for a short DAPT study for patients undergoing high bleeding risk patients undergoing PCI. So in this trial, we have a randomizations of patients into 2 different groups, one group to receive residue Onyx and the other group to receive biofreedom. So the comparator biofreedom is obviously has been proven in the liters-free to be safe with 1 month of DAPT. And so the outcome of this study was to look at the primary safety endpoint of cardiac death, myocardial infarction, or stent thrombosis. And so as we look at the inclusion criteria for this particular study, the HBR inclusion criteria were mainly that of elderly patients of more than 75 years of age, followed by patients who are on oral anticoagulants. So we all agree that this is a group of patients that are considered to be high bleeding risk. And so when you look at the data for Onyx 1 at 1 year as well as 2 years, you can see that there actually no difference in terms of safety and efficacy, particularly from their primary safety endpoint of cardiac death, myocardial infarction, and stent thrombosis when you compare Resolute Onyx with that of BioFreedom stent. But interestingly, at 1 year of follow-up, if you look at the individual endpoint of spontaneous myocardial infarction, as well as the risk of definite or stent thrombosis, you can see that actually it favors Resolute Onyx stent compared to BioFreedom. And interestingly as well, when you look at 2 years and looking at the clinically driven target vessel revascularization, the data seems to again favor the use of Resolute Onyx. So when you combine Resolute Onyx together with a US as well as Japan single-arm registry study and then forming what we call the Onyx 1 Clear, and looking at this huge populations here of about 1,500 people, and then you follow them up to 1 year, again, you can see that the curves are pretty much hugging each other, that actually it is a safe technology, it's a safe stent to use with a short DAPT duration of 1 month. So what this study shows that beyond 1 month, the safety and effectiveness of Resolute Onyx continue to be observed through 1 year. And even in the high-risk group of patients, diabetic subgroup with greater lesion complexity, there was actually no difference in terms of major adverse cardiac event. So with that as a background, I'd like to invite Dr. T.K. Ong now to share with us a case of high bleeding risk in which he managed undergoing a complex PCI procedure. TK.
In this presentation, I will talk about how to do complex PCI in patients with high bleeding risk. PCI in high bleeding risk patients should follow the following principles. First, we must recognize that this is a high bleeding risk patient. In addition, there must be a clear indication for the PCI, and this might require some form of functional testing, either before or during the procedure. And during PCI, we must choose a strategy and device that will allow us to shorten the DAPT regimen. Let me illustrate with 2 cases. The first is a 50-year-old lady with diabetes, hypertension, anemia, dyspepsia, and end-stage renal failure on dialysis. She was diagnosed with 3-vessel disease 3 years ago, and PCI to the LAD and RCA was done at that time. She started having problems during dialysis recently and was admitted with 1 episode of severe hypotension and was diagnosed to have non-STEMI based on dynamic changes in the cardiac biomarkers. So clearly, this was a high bleeding risk patient and some form of revascularization was indicated. A diagnostic angiogram showed pattern stents in the RCA and LAD. So the culprit was the proximal circumflex lesion that started from the ostium. Treatment of the ostial circumflex will require treatment of the left main as well. In addition, a short DAPT regimen was indicated since this was a high bleeding risk patient. So in this case, intravascular imaging is important to tell us, for instance, whether debulking was necessary based on the amount of calcium, whether treatment of the side branch, that is the LAD, was necessary for sizing of the vessels, and to determine the landing zones for the stent. It was decided that a single stent strategy was possible. The procedure started with lesion preparation, first with a non-compliant scoring balloon that's slightly smaller than the reference vessel diameter, followed by a non-compliant balloon sized to the reference vessel diameter. To reduce metal burden, it was decided to do so-called spot stenting of the circumflex ostium. Obviously, we should try not to lose the wire in the other branch, like what they did in this case. Luckily, they managed to rewire the LAD without any problem. After that, pot and kissing balloon inflation. After that, pulse and kissing balloon inflation was done. IVERS was repeated at various stages to assess the result and plan the subsequent steps. The ostium of the LAD was deemed to be well preserved with good minimal lumen area. So perhaps there was no need to do anything more in the LAD. However, because there was concern whether the kissing balloon inflation might have caused injury to the endothelium, a DCB was deployed at nominal pressure. Then this was followed by final port and IVERS to confirm good stent expansion and apposition. And this was the final result. Now, the question is intravascular imaging mandatory in all high bleeding risk cases? Perhaps not. This second case was a 70-year-old man with single vessel disease who was initially treated medically. However, because of ischemia just prior to surgery for cancer, we were asked to perform coronary revascularization for him. As you can see, he had a diffusely diseased LAD with a severe stenosis at the LAD-D1 bifurcation. The case was done without imaging. As always, good lesion preparation is important. And because it's a long lesion, you might need to use more than one balloon of different sizes. Not surprisingly, after good and aggressive lesion preparation, you might sometimes end up with ugly dissections like what you see here. So obviously the lesion had to be stented. Because the patient was planned for cancer surgery, we chose stents that allowed us to shorten the APT to 1 month. In this case, we used the Resolute Onyx. The immediate post-stenting result was not good enough, as you can see on the left. So the stents had to be optimized with high pressure post-dilatation using non-compliant balloons of different sizes. The smaller one for the mid-LAD and the larger one for the segment proximal to the bifurcation. And this will allow us to get a final result that look like this, with symmetry flow in both the LAD and the diagonal branch. In summary, PCI in a high bleeding risk patient follows the basic rules of PCI. Keep it simple. Choose a strategy and devices that allow a shortened DAPT regimen. Use whatever resources you have to get the best possible result. Last but not least, we must first do no harm. Remember, the aim of PCI should be to relieve ischemia and not to produce a beautiful angiogram. Thank you.
Thank you very much, TK. Indeed, getting a right outcomes for patients is critical as we manage our patients in our daily practice. I'm not sure, is Shaifu on with us? Shaifu, yes, hi. I like this TK's approach of using image guidance to do a PCI in somebody with high bleeding risk, and also adopting a simple strategy, as much as you can without resorting to too complex a procedure. Just tell me, how important is clinical trial to you in terms of selections of the right stent for patients with high bleeding risk? Do you only choose stents such as Resolute Onyx because it's got Onyx 1 or other stent? So how important is clinical data to you in your daily practice?
Thank you, Ethan. Great lecture by TK. In fact, we are seeing a lot of patients with high bleeding risk. If you look into literature, it's about 40% of time we are getting these sort of patients, and indeed it is an important thing that we deal with the day-to-day things. We need evidence, definitely. Many years ago, we do not have all this. We are bound to use balloons, we are bound to use bare metal stents, and now we are concerned about drug-eluting stent, with everybody saying that it should be 6 to 12 months of DAPT. But now with the new data, we are having lead-SP, for instance. We are having Onyx 1. We are also having other trials like the Zions, the 28. So those are the things, and there are also some new trials coming from Biotronic, for instance. And these are all awaiting, data for us. So, answer your question, yes, we are bound to use our evidence from these clinical trials, but I'm sure there'll be more and more data coming with more stents which are safer for short DAPT for high bleeding risk patients.
So if you want to choose if you want to shorten the DAPT in somebody undergoing a high-risk PCI, TK say imaging is not absolutely necessary all the time. What is your take on that?
I would agree with TK, but because in majority of time, not everybody has the chance to use imaging. So I would say those who are in the smaller hospitals may not be having IVUS or OCT. But if that happens to me, then I will ensure that the vessel size are well matched with the post-dilatation balloon. Like in the TK's case just now, he used 3.0 and 3.75 NC balloon after putting stents in the proximal LIG in the second case. So if you can't image, just make sure that you have the best, NC size balloon before you end the procedure.
So Paul, so would imaging be something that you will go for? I mean, especially in somebody with high bleeding risk and you want to make sure that the stent is properly exposed, is properly landed and so forth, just so that you have the added level of confidence in treating your patients with shorter DAPT.
Absolutely, Hui-Chim. I think even more important for the HPR patient because you are trying, or we are trying to reduce the duration or the protection of your DAPT. So one hand, you pull away the safety net, you really want to make sure that the procedure was done perfect before the patient come off the table. And one of the ways to achieve that is actually using the abundance use and very low threshold of using intravascular imaging. I also particularly like the way TK mentioned about the use of physiology to make sure that you're only dealing with lesions that are absolutely necessary to do. So in a lot of times, we come across triple vessel disease in this rather complex group of patients. We want to keep the procedure simple, using intravascular imaging to get optimal results, but we also want to avoid doing lesions unnecessarily, and hence keeping the amount of metal and intervention in the coronary tree to the bare minimum.
Yeah, so I was just looking at the first case that TK Ong shared, and he used a drug-eluting balloon to do a kissing for the ostium of the LAD artery. So Paul, is that evidence supported?
TK is a key opinion leader when it's come to drug-coated balloons. Okay, so I'm sure some consensus work that he will come up with will probably make it there somewhere. But I think maybe again would be one of those situations that we might slightly have different approach. Keeping the procedure simple in this group of patients probably would be my preference. What do you think, Hui-Chim?
I'm not so convinced of the DEB over POBA in the de novo lesions and the native vessel that is large in the LAD artery. Perhaps there's some data on the comparison of DEB with drug-eluting stents in small vessels, but certainly not in large vessels. We just need some evidence. TK, what is your take? Why do you do a DEB on the ostium or the LAD here?
Yes, I agree with you. There's actually no evidence for the use of DCB in this LAD. And we will probably, and of course the EBC mains trial tells us that we don't need to do anything about the LAD. The single stent into the circumference will be sufficient. So I think it was just the cardiologists treating ourselves, thinking that it will give us the additional advantage. But it was probably just a balloon wasted. It probably made no difference. Yeah.
Shaifu, I want to come back to you again on the TK's second case. There was a patient who was supposed to go for a cancer operations and then got to go for a coronary revascularization procedure because he had some chest pain and so forth. And so the question, we always been faced with this dilemma that you have to consider coronary revascularization just so that the surgical outcomes perioperatively can be enhanced. But this has never been backed up by any data. Certainly if you look at I remember a long trial like CARP and DECREASE 5, that the routine coronary revascularizations before any non-cardiac surgery actually makes no difference as far as the outcomes of a patient going through an operation. So what is your thought process? I mean, how do how do you decide when not to do a coronary revascularizations before a non-cardiac surgery?
Thank you, Hichem. That is a very important question, really. I wouldn't like to be in TK's boots to handle this patient, but I believe the physician himself, at the end of the day, will have to decide on what is the best for his patient, because nobody else knows about that patient, and the patient cannot even enter any multiple trials or whatsoever to place him to be, advised as such. So in this particular case, I would have discussed with the multidisciplinary team in my hospital, whereby I will get the surgeons involved, I will get those who are involved with the cancer treatment, and the further subsequent management for the patient. We will sit down and discuss what will be the best outcome. If surgeons think that this is a non-surgical case from the word go, then we'll have to plan something for him. And from that on, we will discuss whether a stent or a drug-eluting balloon or just medical therapy, like what TK mentioned earlier. Is it a necessity? Is the patient really need a PCI? But of course, the second case has very tight lesion in the LAD. And at the end of the day, I will echo what TK mentioned again, is to reduce ischemia. That's the plan, because that in the end will decide whether the patient can undergo the cancer surgery safely. So just do the minimum, ensure there is no complications whatsoever, and leave the rest to the treating cancer team.
So Chiteng, I want to ask you the same questions again. So if these patients go for a PCI, what stent would you use? How long would you defer the operations after your PCI? Would you tell the surgeons to go on one antiplatelet perioperatively? And would you restart a dual antiplatelet therapy after the surgery?
Okay, thanks.
Sorry. This is a practical question.
Just a simple question there. So, okay, 4 parts to that, right? I think, what stent would I use? So, I think, most stents we believe are equal, but some stents have more evidence than others. So, we got to go with where the evidence stays, right? So, we have evidence for certain stents, and the Onyx stent definitely has evidence for short DAPT duration. I think the next question is DAPT duration. I think we have to bear in mind that all these trials, Onyx 1, Leaders Free, etc., they are not examining DAPT duration. They're looking at stent types. Okay, and particularly in Leaders Free, you know that these patients actually have a higher event rate, even though they are, in this trial. So we can't sell this as, you can just give 1 month DAPT and everything will be fine. They are higher risk. And they're higher risk not just because of the stent or the PCI, but they're higher risk because of their comorbidities. So I think that's something that we need to impress upon the patient as well as the surgeon. So how long you want to keep going with the DAPT? When are you going to convert them to single antiplatelet? This is a conversation we need to have with the surgeon and with the patient. The surgeon, how comfortable are you to keep going with this DAPT? If you say that this cancer surgery cannot wait 2 months, then okay, we've got to bite the bullet. Tell the patient, no choice. We've got to go and treat your cancer because your cancer is going to take over. And, we have to take that chance and we got to, convert you to single antiplatelet, maybe 6 weeks, 4 weeks, whatever. So I think that's how I normally do it in terms of when I talk to my patients.
Certainly a lot of factors to consider when deciding on the ultimate management of patients. So Paul, high bleeding risk occurs in about 30% of patients undergoing PCI. Are there any sort of validation study that you know of in Asia which tells us that high bleeding risk patients are at a higher risk for adverse outcomes?
I think we have come across, quite a lot of data, and we heard about the Asian paradox, and maybe the Asian, because of a genetic predisposition to the P2Y12 resistance, maybe there will be some issues with the equation between balancing embolic risk with bleeding risk. But the AICT-HPR criteria that you mentioned, and also the precise step score that some of us are using, and in the master DAPT trial also adopted that score as one of the bleeding risk assessment. That actually has been validated by the Korean group, and I believe that the 1-year outcome, the score for both the AICT-HPR and the precise step actually quite accurately predict the bleeding risk in Asian patients, Hui-Chin?
Yes, certainly the more and more emerging data are coming forward, especially from this part of the world. But I have to say that in my daily practice, it's very hard to go and calculate the precise depth score of patients or acuity, or there's just sometimes by just clinical assessments based on experience and judgment, you can pretty much tell who are the patients that are high bleeding risk. So I think we have answered most of our key questions for today. Let me just go through some of the key pointers that perhaps the audience can take home with. I think Renal Denervation has proven itself, at least with the simplicity system in the global simplicity registry, that it is associated with a meaningful reduction of major adverse cardiac event in high-risk subgroups of patients with effect lasting at least even up to 3 years of follow-up. So renal denervation is now a feasible treatment options to be considered in conjunction with medications, as well as, of course, taking into patients' preference into considerations. And we know from the ONYX-1 study that Resolute ONYX DES showed continued safety and efficacy in complex high-risk patients with 1 month DAPT, and this is an effect that is persistent even up to 2 years of follow-up with the ONYX-1 global study. So with that, I think I'd like to thank my fellow discussants, as well as my remote experts, together with the audience here and the studio, for attending this symposium. So stay on with us, and coming up next will be our TEVI in Asia Pacific 2021. Thank you very much.